Hello, welcome. And this is the um, Zooming through ID with Dr. Gopal. And thanks for joining. We are going to present a very interesting topic today that is endocarditis. I feel like every physician, they need to know very well about endocarditis, especially it is one of the great topics in ID, and we see a lot of patients, and it's very important. Um, that topic is very dear to my heart because I did my fellowship at Duke, and that is a big facility where I've seen a lot of endocarditis patients, and we get all the guidelines from the Duke. Um, Today, the topic that we are going to talk is, mainly about Duke criteria, and the author is, I have to say that it is Dr. Vance Fowler, and I personally know him from my training, and he was my mentor, and he has the biggest lab where they do a lot of Staph aureus. They study about Staph aureus in detail, and I respect him well, and he's the guru of kind of that topic. I'm going to introduce you today to Lynette, and she's going to talk about the topic, and she will do the presentation. And Lynette, I have rounded with her twice, and she's excellent. She has great bedside manners, and she's very enthusiastic to learn. And her interest is cardiology. And Without further ado, she's the intern. And let me introduce you to Lynette.
Hi everyone, my name is Dr. Leon. I'm one of Dr. Gopal's interns, and I'm going to be presenting endocarditis. Can you see my
Excellent,
window?
excellent. Yeah, it's great.
Perfect.
Mhm.
Thank you. The 2023 update by the International Society for Cardiovascular Infectious Disease. Sorry, we use the Duke's criteria because they provide a structural and evidence-based approach to identifying infective endocarditis that is both highly specific and highly sensitive. The 2023 update by the International Society for Cardiovascular and Infectious Disease further enhances the Duke criteria by incorporating advancements in microbiology and imaging techniques such as polymerase chain reaction and position emission tomography with 18-fluorodeoxyglucose, and by expanding the list of typical microorganisms predisposing conditions. This update aims to improve both the sensitivity and specificity of the criteria, making them more applicable to clinical practice. Overall, the Duke criteria are used because they offer a comprehensive and validated framework for diagnosing infective endocarditis. So, what is endocarditis, you might ask? Endocarditis is an infection of the inner lining of the heart chambers and valves. It is often caused by bacteria, fungi, or other microorganisms entering the bloodstream. What are some risk factors? Risk factors are male sex, age greater than 60, acquired valvular diseases. Some of the most high yield ones are rheumatic heart disease, aortic stenosis, or degenerative valvular disease, prosthetic heart valves, congenital heart defects, previous infective endocarditis, and cardiac implantable electric devices. Non-cardiac risk factors are poor dental status, dental procedures, non-sterile venous injections such as IV drug users, intravascular devices, surgery, chronic hemodialysis, or immunocompromised, such infections such as HIV, diabetes, or having other infections such as UTI or periodontal infections. Some of the symptoms of infective endocarditis that we might see are fevers and chills, tachycardia, general malaise, maybe weakness, weight loss, cough, and even pleuritic chest pain. Patients with subacute infective endocarditis often present with nonspecific flu-like symptoms also. Or it could just be a sign of acute sepsis. Acute sepsis is basically is- acute sepsis is basically two SIRS criteria plus a suspected or confirmed underlying infection. SIRS is basically diagnosed if greater than two of the following are met. A temperature greater than 38 degrees Celsius, heart rate greater than 90, respiratory rate greater than 20, or WBCs greater than 12 or less than 4,000. Cardiac manifestations of infective endocarditis, the most popular one and high yield would be signs of a new murmur, for example. And then some of the findings that we would see cutaneously of infective endocarditis would be petechiae, Janeway lesions, renal failure, potentially. How do we diagnose infective
Um,
endocarditis?
yeah, that so in terms of the Janeway lesions, Osler's nodes, and all those things, we have better diagnostics these days. So we are diagnosing them early. So we are seeing those scenarios less and less. But and in terms of the murmur, it will be a new murmur. So that will be, yeah. Mhm.
How do we diagnose infective endocarditis? We use the Duke's criteria to diagnose endocarditis, supported by additional evidences, such as clinical evidence. These include the observable signs and test results, such as blood cultures and heart imaging, and pathologic evidence. This involves identifying the bacteria or damaged tissues through direct examination of heart tissue samples. What are the Duke criteria? It was established in 1994, modified in 2000, and now updated again in 2023. The purpose is to standardize the diagnosis of infective endocarditis, and new updates address the microbiology, the imaging, and the clinical diagnostics. Why this update, you might ask? Advances in microbiology diagnosis, such as PCR and metagenomics, a growing role of imaging, such as PET scan, cardiac CT, and an increased presence of risk factors like cardiac implantable electric devices, updated pathologic criteria, new technique to detect infection. The 2023 Duke now uses advanced techniques like 16S, 18S, or RNA PCR, which is a special test to detect germs in samples. A fish sequence, a test that can find germs in heart valves. All these tools detect infections faster and more accurately. Clinical criteria are the blood culture tests. Blood culture samples are taken to check for typical microorganisms that cause infective endocarditis. If these microorganisms match those typically found in endocarditis, is a strong sign that you have the disease. And then some of these typical organisms that we would find would be Staphylococcus aureus, Enterococcus fecalis.
So the in terms of Lynette, yeah, in terms of the microorganisms, just to say that endocarditis, Staph aureus. I mean, there has been multiple data and multiple articles, but in general, Staph aureus is the biggest player. About 40 to 50% would be Staph species. Among that, Staph aureus would be about 30 to 40% would be Staph aureus, and then Staph epidermidis would be about the rest 10% would be Staph epidermidis. So that is one of the biggest. And then comes strep, that would be about 25 to 30% cases. And viridans will be about 20%, and strep gallolyticus, that is with the association with the strep bovis and colon cancer and all, that will be about 5% of cases. And then the strep group B, C, and D would be about 5%. In terms of enterococcus, that would be about 10% of, in general, the endocarditis cases, 10% would be enterococcus. And then we have our culture negative endocarditis that will be about 3 to 5% of cases. And then HASEC would be about 1 to 2%. Yeah.
And because they are culture negative, it's important for us to get a positive culture before we start antibiotics, because if not, it would be very difficult
Mhm,
for us
mhm.
to identify. For atypical organisms like the hack group, we would need at least three separate blood cultures, and specialized tests now that it's incorporated with this new update include the PCR or the metagenomic sequencing. I'm sorry.
Oh, you're fine.
And then
Yeah.
and special subgroups in patients with intracardiac prostases. These are the organisms that are most common culprits.
Mhm.
And then the clinical requirement, something that's new, is typical microorganisms, two or more separate culture sets at least. And then for atypical, we need at least three or more separate blood cultures. Something interesting now is that before, blood cultures were a must and were a definitive part of the criteria, but now it's more of a suggestion rather than a requirement, but it's still highly encouraged in order to practice better clinical practices and reducing cultural contamination. Alternative tests that we're using now with this new update include PCR for C. burnetii or Bartonella and T. whoopii. Metagnomic sequencing is a method basically that sequences the DNA in order to identify and analyze the diversity and function of the organism.
Just to
Some of
comment about the culture negative endocarditis.
the
So the number one reason would be prior antibiotic use. So sometimes people will get antibiotics for a sinus infection. They will say they will think it is a UTI or something, and without doing the blood culture, in the community, they will get antibiotics. So that is number one reason for the culture negative. And then we have the fastidious organisms, the HASEC, Haemophilus, aggregator Cardiobacterium, Eikenella, and Kingenella. And with the modern blood culture techniques and media, we are able to grow. Then Abeotrophia is one of those defective, species which is difficult to grow. Then we have the non-cultivable organisms. These are Bartonella, Quintana is one of them, and then Coxiella. Yeah, so there it is. Then we have the Coxiella burnetii, and then Tropharima whippeli, that is a Whipple disease, and also some of the Legionella species. It's hard to grow. Then rare scenarios, there can be mold, mold like aspergillus. It is very rare, but it can happen. So it is very difficult to grow. But the yeast will grow. The candida yeast will grow in the cultures and the blood cultures. And then when we think about the other thing that we have to consider when we don't see the culture, is it really endocarditis or is it not endocarditis like the Lippmann Sachs, myxoma and merantic endocarditis. And then, you have to think about the antiphospholipid antibody syndrome. These kind of scenarios, of course, the patients won't have fever, they won't have other stigmata, they won't have the glomerulonephritis and all kinds of stuff. Yeah. And then among the culture negative, in terms of the questions in the board, there is usually there will be if they are thinking about Q fever, it will be a patient with some kind of animal exposure that will be there. And then the Whipple's disease would be patients with GI symptoms, weight loss, and it will be like all of those will be listed to think more about the Whipple.
And then they would also have some neurological symptom as well as some arthritic symptoms as well.
All those. Yeah. Excellent.
Some of the imaging criteria that we use today, one of the most sensitive and specific would be the TEE. Usually, you can also use a TTE, which is in non-invasive and ideally should be performed within the first 12 hours. And if no complications are suspected at that point, then it's best to just to go with the TEE, which is a goal of standard. It's very highly sensitive. Findings, we would see valvular vegetations, hyperechoic mobile masses located on the valves, mural endocardium, or prosthetic material, depending if somebody has a new valve, for example, or like an abscess, for example. We would see evidence of the regurgitation on the echo. Um, TEE is about 90% more sensitive compared to TTE, which is about 75%, and it is much more reliable in ruling out infective endocarditis in patients with moderate to high pretest probability.
So
The
the prosthetic valve, we definitely need to do a TE. Yeah. Patients with prosthetic valve.
Some of the new updates are surgical evidence as well. Like, let's say if a patient has a terrible abscess and you have to open them up, having us seeing it physically, such as the vegetation or an abscess, it's now being added as one of the criteria. Minor criteria, predisposing conditions, for example, is another one, such as cardiac prosthetic material, transcatheter valve implants, repair endovascular leads, for example, congenital heart conditions, prior diagnosis of infective endocarditis, and then vascular phenomenon, such as having evidence of like cerebral abscess or splenic abscess, along with a glomerulonephritis. And then overall, this is just a summary basically of the updates of what we spoke about earlier, the Barnatella, the T-Whoopii, the use of this new diagnostic method, such as the PET-CT,
Mhm.
and then the minor criteria, the predisposing heart abnormalities, having fevers, having positive blood cultures, and then the new valvular regurgitation and auscultation, for example. And then interpretation would be definitive infective endocarditis would be greater than one pathologic criteria, which is the organisms that we spoke about in previous slides, and then greater than two major criteria, or one major criteria and then three minor, or greater than five minor. Possible infective endocarditis high pretest probability would be one major criteria and then one to two minor or three minor. And then this is just like a summary of both major and minor. And then high yield testable endocarditis facts would be the prophylaxis. Cardiac risk factors requiring prophylaxis for procedures that may cause bacteremia, such as the presence of a valve, prior history of an infective endocarditis, or congenital heart disease. But this is a very interesting one because it's not just congenital heart disease. It's congenital heart disease that's been repaired within the last 6 months, or congenital heart disease that have like a residual shunt or regurgitation, or a cyanotic heart disease. Procedures requiring prophylaxis would be dental procedures, including tooth extractions or undergoing pulmonary lavage, anything that is entering the oral pharyngeal pathway, or even placement of an SIED, the cardiac implantable cardiac device, surgical placement of prosthetic cardiac or intravascular material, for example. And then common regimens usually use the antibiotics if they have no penicillin allergy. You can use amoxicillin or ampicillin or cefazolin. And then if they have a penicillin allergy, you can use a macrolide or doxycycline. And then prior to the cardiac implantable electric device, then it's very important to use cefazolin as well to prevent to decrease the risk of infection. And then a couple of questions.
Mhm.
A 66-year-old woman is brought to the ED because of fever, chills, night sweats, and progressive shortness of breath for 1 week. She also reports generalized fatigue and nausea. She has type 2 diabetes And hypothyroidism, current medications include metformin, sitagliptin, and levothyroxine. She appears very ill and she has 101.7 degrees fever. Her pulse is 104. She's tachy. Blood pressure is 160 over 90. Examination shows pale conjunctivae and small non-tender hemorrhagic macules over her palms and soles. Janeway lesions. Uh, Crackles are heard in the lung bases, and a grade 2 out of 6 mid-diastolic murmur is heard over the third left intercostal space and is accentuated by leaning forward. The spleen is also palpated 1 to 2 centimeters below the left costal margin, and then these are her labs. So she has a bit of anemia as well as leukocytosis, indicating infection, and she seems to have a nephritis. She has blood in her urine, a 2 plus, and then echo shows multiple vegetations on cardiac valves. And she's growing as I can't pronounce that one.
I guess, yeah.
She
Mhm.
is treated with ampicillin and gentamicin 2 weeks, and her symptoms resolved. Repeat echo 3 weeks shows mild aortic regurgitation with no vegetations. Which of the following is the most appropriate next best step? For this one, if we go through the major and minor criteria, she does have evidence of clinical evidence of possible infective endocarditis, which is the cutaneous manifestations, the hemorrhagic macules over the palms and soles. She is growing a temperature, and she does have evidence of a murmur, as well as she has another cutaneous manifestation or peripheral manifestation, which would be the glomerular nephritis seen on UA. And she also has imaging evidence of the vegetations, and she's growing an atypical, the Escalactis, which is highly associated with colon cancer, actually, which is a very high yield fact to know and very testable. So then, based on that information, the most likely answer at that point would be a colonoscopy.
Yes, yeah. Okay, great.
And then this is the evidence that supports it. And then down here, it shows you a hint. Do criteria with 2 major criteria, typical organism, as well as valvular vegetations, and then 3 minor. The fever, Janeway lesions, and signs of glomerulonephritis on UA. And then this is the answer, which is colonoscopy. This bacteria can be found in the normal bowel flora, and it increases your chances of colon cancer. That's why it's very important to undergo a colonoscopy.
This is very testable, as well as you will see in your wards too, because patients with this, and then the next thing you need to do would be ask for a GI consult and, colonoscopy. Okay, great question.
Another question would be this one is going to test prophylaxis. A 72-year-old male comes to the physician for medical clearance for molar extractions. He reports he's able to climb 3 flights of stairs without experiencing any shortness of breath, past medical history of diabetes, ischemic heart disease, and he underwent valve replacement for aortic stenosis last year. Based on that information, which of the following is the most appropriate next best step? In this case, because he is at high risk population, he has a valve. The most likely answer would be administer oral amoxicillin 1 hour before the procedure. And then this is the most important components of this question, and then this is the answer explanation. Antimicrobial prophylaxis for prevention of infective endocarditis is recommended for high-risk patient population, such as prosthetic heart valves and history of unrepaired cyanotic congenital heart disease. And antibiotic regimen should be administered 30 to 60 minutes prior to the high-risk procedure.
Okay. That's also very testable, question. Yeah.
And then one more question. A 36-year-old male comes to the physician for evaluation of low-grade fever during a non-productive cough for 4 weeks now. During this period, he's had fatigue, difficulty breathing. Notable for this patient is that 3 months ago, he underwent a prosthetic valve replacement due to high-grade aortic stenosis, and he had a colonoscopy last year. Currently, the patient appears very lethargic. He has this symptom on his nails. Temperature, he has a fever. He's a bit tacky. Rails are heard on auscultation, and he has a new murmur. Photograph of the right index finger shown. He has leukocytosis. He has increased inflammatory markers, and which of the following is the most likely causative organism? So a hint for this one would be the fact that he underwent a valve replacement. Now he has a fever. Now he has a cutaneous manifestation of infective endocarditis, and common association with prosthetic valve would be this particular organism, Staphylococcus epidermidis, which is the answer.
Because see, the when you have a blood culture positive with staph epidermidis, if somebody has, no prosthetic valve or anything, most of the cases it will be 1 out of 2 or 2 out of 2, whatever it is, staph epidermidis is deemed a contaminant. But this is one scenario when patients have prosthetic valve, and when you see staph epidermidis, you need to be thinking about, you need to ask for a TE. I mean, this could be endocarditis. So that is like two extremes. Like one patient, so history is important. We need to know that this is prosthetic valve endocarditis when you see that staph epidermidis in the blood cultures. So great question. Yeah. Mm-hmm.
Thank you, everyone. That concludes my presentation.
Excellent, excellent, great. It was good job. Just a couple of points to make. I mean, not in the endocarditis, but in that area is there is a new there has been identification about Mycobacterium chimera. There is a lot of cases in Europe and everything. That's been associated with open heart surgery, and that is associated with they have this. Heater cooler unit that they use during surgery, and the mycobacteria, atypical mycobacteria, are waterbugs, so there is contamination, and that has there has been many cases of mycobacterium chimera, so that is something interesting to read up about. We didn't talk about treatment of endocarditis, but treatment is a few points just in general. Like endocarditis is a condition where the regimen that we use should kill the pathogen. So it has to be a bactericidal regimen. And most scenarios we have to use prolonged course of treatment for endocarditis. And then the other thing about the treatment that we have to make sure is source control. So if we don't control the source, I mean, we are not going to cure the patient. And then we have to use appropriate dosing. We have to use intensive dosing, prolonged dosing. So those are some key aspects about endocarditis treatment. But treatment is another, presentation, and different bacteria, based on the pathogen, we do the treatment. Okay, this is excellent. Good job.
Thank
Thank
you.
you. Thank you. Okay.